Hello everyone, and welcome to NREMTPracticeExam.com. I'm your host Matt, and today we're going through the ultimate video study guide to help you pass your NREMT exam. Before we start, let's quickly cover how the NREMT officially breaks down the exam. They have 5 main content areas with specific weightages. Airway, respiration, and ventilation is 18 to 22%. Cardiology and resuscitation is 20 to 24%. Trauma is 14 to 18%. The largest section is medical, obstetrics, and gynecology at 27 to 31%. And finally, EMS Operations is 10 to 14%. Now, to make all of that information easier to study and master, we've organized our guide into 9 focused sections. In this video, we will cover airway, breathing and ventilation, cardiology and resuscitation, trauma, medical emergencies, EMS operations, pharmacology basics, obstetrics and gynecology, patient assessment, and finally, pediatric and geriatric care. Before we jump into our first section, we want to give you a quick disclaimer. Although this video will be around 30 minutes long, it is primarily an overview of the study guide. Therefore, we recommend using this video to get an idea of the topic and a basic understanding of it. Then visit our website to read more or download the full study guide. That will give you the finer details we might skip in this video. Let's get started with our first and most critical section. Section 1, Airway, Breathing, and Ventilation. A good airway is the foundation of everything we do. First, let's cover the anatomy. The airway is divided into the upper and lower sections. The upper airway warms, filters, and moistens the air. It includes the nose and mouth, the pharynx, your throat, the larynx, your voice box, the epiglottis, which is a flap that covers your windpipe when you swallow, and the cricoid cartilage, which is the only complete ring of cartilage in the upper airway. The lower airway's only job is to get air to your lungs. It starts with the trachea, your windpipe, which splits at a point called the carina. It then branches into smaller and smaller tubes called the bronchi and bronchioles. At the very end are the alveoli, millions of tiny air sacs where oxygen enters the blood and carbon dioxide leaves it. Now, let's talk about opening a patient's airway. This is always priority number 1. In an unresponsive patient, the tongue is the most common airway obstruction. For most patients, you'll use the ABC approach, airway, breathing, circulation. However, if your patient has life-threatening external bleeding, you must switch to CAB, control the bleeding first. To open the airway, you have 2 main manual maneuvers. The head tilt chin left is for patients with no suspected spinal injury. The jaw thrust maneuver is for patients with a suspected spinal injury because it opens the airway without moving the neck. A critical point, if the jaw thrust fails, you must use the head tilt chin lift. A blocked airway will kill your patient faster than a potential spinal injury. For a foreign body airway obstruction or choking, if it's a mild obstruction and the patient can still cough or talk, just encourage them to keep coughing. If it's a severe obstruction and they can't breathe, cough, or talk, for a conscious adult or child, perform abdominal thrusts, the Heimlich maneuver. For a conscious pregnant or obese patient, perform chest thrusts. For a conscious infant, perform 5 back blows followed by 5 chest thrusts. If any patient becomes unresponsive, immediately start CPR, beginning with chest compressions. Before giving breaths, look inside the mouth for the object and only remove it if you can see it. This is a critical point. Suctioning is used to clear fluids. Your unit must generate at least 300 millimeters of vacuum. A rigid Yonkauer catheter is for the mouth, while a flexible French catheter is for the nose or stoma. To use it, measure from the corner of the mouth to the earlobe, insert only as far as you can see, and apply suction only while withdrawing. Remember these crucial time limits, no longer than 15 seconds for an adult, 10 seconds for a child, and 5 seconds for an infant. When assessing breathing, you need to know your normal respiratory rates. For an adult, it's 12 to 20 breaths per minute. For an infant, it's 30 to 60. Look for signs of inadequate breathing, a rate that's too fast or too slow, an irregular rhythm, shallow chest expansion, the use of accessory muscles, retractions, nasal flaring, or cyanosis, bluish skin. Early signs of hypoxia, or lack of oxygen, include restlessness, anxiety, and a fast heart rate. Late signs include altered mental status, confusion, and a slow heart rate, which is especially bad in children. A quick note on the pulse oximeter. It's a valuable tool, but it has a critical limitation. In cases of carbon monoxide poisoning, it will give a falsely high reading like 100%, even when the patient is severely hypoxic. This is a very common test question. You also need to know your lung sounds. Stridor is a high-pitched, harsh sound on inhalation, indicating an upper airway obstruction. Wheezing is a high-pitched whistling sound on exhalation, common in asthma and caused by lower airway constriction. Rhonchi are low-pitched rattling sounds like snoring, suggesting mucus in the larger airways. Crackles or rales are wet, popping sounds from fluid in the alveoli, classic for pulmonary edema. Gurgling means fluid in the upper airway, suction immediately. Snoring indicates the tongue is partially obstructing the airway. To keep the airway open, we use adjuncts. An OPA, or oropharyngeal airway, is a curved plastic device for unresponsive patients without a gag reflex. Size it by measuring from the corner of the mouth to the earlobe. An NPA, or nasopharyngeal airway, is a soft tube for patients with an intact gag reflex who won't tolerate an OPA. Size it by measuring from the tip of the nose to the earlobe. Do not use it if you suspect a basilar skull fracture. For oxygen delivery, a full cylinder contains about 2,000 psi. Your main delivery devices are the nasal cannula for mild hypoxia at 1 to 6 liters per minute. The non-rebreather mask, or NRB, is the preferred device for hypoxic patients with adequate breathing at 10 to 15 liters per minute. Always fill the reservoir bag first. And the bag valve mask, or BVM, for patients in respiratory arrest or with inadequate breathing. Ventilate an adult once every 6 seconds and a child or infant once every 2 to 3 seconds with just enough air to see the chest rise. Finally, a quick review of respiratory emergencies. Obstructive diseases like asthma and COPD cause wheezing from bronchoconstriction. Acute pulmonary edema, often from congestive heart failure, causes fluid to build up in the alveoli, leading to crackles. Infectious diseases like pneumonia, life-threatening epiglottis, high fever, drooling, and stridor, and croup, seal bark cough and stridor, can cause airway swelling. Attention pneumothorax is a critical emergency where air gets trapped in the chest cavity, collapsing a lung and compressing the heart. Key signs are severe respiratory distress, absent lung sounds on one side, and jugular vein distension. Remember that children are not small adults. Their tongues are proportionally larger, their tracheas are smaller, and they are belly breathers. A slow heart rate in a child is a sign of critical hypoxia and is a very bad sign.
Section 2. Cardiology and Resuscitation. All right, let's move into cardiology and resuscitation, a huge part of the exam. We'll start with anatomy. The heart wall has 3 layers, the epicardium on the outside, the myocardium, which is the powerful middle muscle, and the endocardium on the inside. The heart has 4 valves to ensure blood flows in one direction, the tricuspid, bicuspid or mitral, pulmonary, and aortic valves. Perfusion is the circulation of blood within an organ to meet its needs. The concept of the perfusion triangle is essential. For perfusion to work, you need all 3 components: the heart, the pump, the blood, the fluid, and the blood vessels, the container. The failure of any one of these parts results in shock. When assessing a cardiac patient, rapidly identify those who are high priority. Anyone with severe chest pain, poor perfusion, pale, cool, sweaty skin, or altered mental status. Let's talk about resuscitation. The chain of survival is critical. It starts with early recognition and calling for help, followed by early, high-quality CPR, rapid defibrillation, and then advanced life support. For CPR, you must start immediately for any patient who is unresponsive, pulseless, and not breathing. The rate is 100 to 120 compressions per minute. The depth is 2 to 2.4 inches for adults. The ratio for an adult is always 30 compressions to 2 breaths for both 1 and 2 rescuers. For a child or infant, it's 30 to 2 for a single rescuer, but it changes to 15 to 2 for 2 rescuers. Your AED or automated external defibrillator is used for any patient who is unresponsive and pulseless. The AED can only shock 2 rhythms: ventricular fibrillation, or VFib, which is chaotic electrical activity, and pulseless ventricular tachycardia, or VTach, which is a very rapid rhythm. The AED will not shock asystole, a flatline, or pulseless electrical activity, PEA. Remember these special considerations. Do not place pads directly over a pacemaker. Remove any medication patches. The vehicle must be stopped for the AED to analyze the rhythm. As an EMT, you'll assist with a few cardiac medications. Always remember the 6 rights of medication administration: right patient, right medication, right dose, right route, right time, and right documentation. Aspirin is an antiplatelet. The dose is 162 to 325 milligrams, and it must be chewed. Nitroglycerin is a vasodilator. The dose is 0.4 milligrams under the tongue. The critical contraindications are a systolic blood pressure less than 100, use of erectile dysfunction medications like Viagra within the past 48 hours, or a head injury. Let's quickly review some specific emergencies. An acute myocardial infarction, or AMI, is a heart attack. Symptoms include crushing chest pain that can radiate to the jaw or left arm. Congestive heart failure, or CHF, is when the heart can't pump effectively. Left-sided failure causes blood to back up into the lungs, leading to pulmonary edema and crackles. Right-sided failure causes blood to back up in the body, leading to jugular vein distension and peripheral edema. An aortic dissection is a tear in the aorta. The classic symptom is a sudden sharp or tearing chest pain that radiates to the back. A cerebral vascular accident, or CVA, is a stroke. Signs include facial droop, arm drift, and slurred speech. Always check a blood glucose level, as hypoglycemia can mimic a stroke. Cardiac tamponade is when fluid fills the sac around the heart, compressing it. The classic signs are known as Beck's triad: hypotension, jugular venous distension, and muffled heart sounds. Finally, shock is a state of inadequate cellular perfusion. In compensated shock, the body is still maintaining blood pressure. You'll see anxiety, a rapid pulse, and cool, clammy skin. In decompensated shock, the body is failing and you'll see a drop in blood pressure, which is a very late sign. You must also know Cushing's triad. This indicates severely elevated intracranial pressure from a head injury and is the opposite of shock. The signs are hypertension with the widening pulse pressure, bradycardia, a slow heart rate, and irregular respirations.
Section 3. Trauma. Welcome to the trauma module of NREMT Study Guide. Let's begin with assessment. The rapid trauma exam is a quick head-to-toe assessment to find life-threatening injuries. A great mnemonic to use is DCAP-BTLS. Deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, and swelling. To assess a patient's level of consciousness, we use the Glasgow Coma Scale, or GCS. This tool scores a patient's eye, verbal, and motor responses. A score of 15 is normal, and a score of 3 is completely unresponsive. A GCS of 8 or less typically indicates a severe head injury. For head and spine trauma, spinal motion restriction is crucial. Use a cervical collar. If you don't have the right size, use a rolled towel and tape the patient's head to the backboard. Only remove a helmet if it interferes with airway management. Be aware of the signs of specific head injuries. Increased intracranial pressure can present with a unilaterally fixed and dilated pupil and Cushing's triad. A basilar skull fracture may show signs like fluid draining from the ears, raccoon eyes, or battle sign, which is bruising behind the ear. An epidural hematoma is an arterial bleed with a classic presentation of losing consciousness, waking up and seeming fine for a period, and then losing consciousness again. A subdural hematoma is a slower venous bleed.
In shock and bleeding, always assume a trauma patient with cool skin and tachycardia has hemorrhagic shock. The trauma-lethal triad is a deadly combination of hypothermia, coagulopathy, impaired blood clotting, and acidosis. For musculoskeletal trauma, a pelvic fracture is a potentially fatal injury due to massive internal bleeding. You must apply a pelvic binder. A femoral shaft fracture can also cause significant blood loss. The treatment is a traction splint. Compartment syndrome is a painful condition where pressure builds within a muscle compartment, restricting blood flow. It develops hours after an injury. For soft tissue injuries, an evisceration is when internal organs protrude from the abdomen. Cover the organs with sterile gauze moistened with sterile saline, then an occlusive dressing. Do not push the organs back in. For an amputation, wrap the amputated part in a sterile dressing, place it in a dry plastic bag, and keep it cool. In chest trauma, a flail chest occurs when 3 or more ribs are fractured in 2 or more places. This causes a segment of the chest wall to move paradoxically, inward on inhalation and outward on exhalation. Burn injuries are classified by depth. Superficial or first degree are red and painful. Partial thickness or second degree cause blistering and intense pain. Full thickness or third degree extend through all skin layers and may be painless because nerve endings are destroyed. Any full thickness burn involving the hands, feet, face, the airway, or genitals is considered severe. For environmental trauma, know the signs of hypothermia. Early signs include shivering. Late signs include loss of coordination and confusion. For heat exhaustion, move the patient to a cool environment and rehydrate them. For eye injuries, a retinal detachment is typically painless but presents with floaters, flashes of light, and the sensation of a curtain across the field of vision.
Section 4. Medical Emergencies. Let's move on to medical emergencies. First, some core principles. A sign is something you can see or measure, like a rash. A symptom is something the patient tells you, like a headache. For an unstable patient, assess vitals every 5 minutes. For a stable patient, every 15 minutes. A BP cuff that is too small will give a falsely high reading. When assessing the abdomen, know your quadrants. The right upper quadrant contains the liver and gallbladder. The left upper quadrant contains the stomach and spleen. The right lower quadrant contains the appendix. The left lower quadrant contains the descending colon. Cullen's sign is bruising around the belly button. Gray-Turner's sign is bruising along the flanks. Kier's sign is referred pain in the left shoulder, a classic sign of a ruptured spleen. For specific abdominal conditions, include appendicitis, which presents with pain that moves to the right lower quadrant. Cholecystitis, or gallbladder inflammation, causes sharp right upper quadrant pain, especially after a fatty meal. Pancreatitis causes severe upper quadrant pain that radiates to the back. In toxicology, you need to recognize overdose syndromes. Opiates cause a classic triad of pinpoint pupils, respiratory depression, and coma. Sympathomimetics, like cocaine, cause hypertension, tachycardia, and dilated pupils. For cholinergics, remember the mnemonic SLUDGEM: salivation, lacrimation, urination, defecation, gastric upset, emesis, and meiosis, or pinpoint pupils. For allergic reactions, you must differentiate between a localized reaction and anaphylaxis. Anaphylaxis is a severe systemic reaction involving 2 or more body systems, such as widespread hives and wheezing. The primary treatment for anaphylaxis is epinephrine. For endocrine emergencies, let's focus on diabetes. Normal blood glucose is 80 to 120. Hypoglycemia, or low blood sugar, has a rapid onset. The skin will be cool, pale, and clammy, and the patient will have neurological signs like altered mental status.
Hyperglycemia, or high blood sugar, has a gradual onset with signs of dehydration, and the skin is often warm and dry. Diabetic ketoacidosis, or DKA, presents with a fruity breath odor and Kussmaul respirations, which are rapid, deep breaths.
Section 5. EMS Operations. Welcome to EMS Operations module. Modern EMS originated in 1966, and the Department of Transportation, or DOT, is the governing body. There are 4 training levels: EMR, EMT, AEMT, and paramedic. A physician medical director authorizes EMTs to provide care through medical control. Online control is speaking directly to a physician. Offline control is following pre-written standing orders. Your safety is paramount. Hand washing is the single most important practice for infection control. Use appropriate personal protective equipment, or PPE, on every call. A HEPA or N95 mask is required for patients with suspected tuberculosis. The scene size-up is the first part of your assessment. The steps are: take standard precautions, ensure scene safety, determine the mechanism of injury or nature of illness, determine the number of patients, and consider if you need additional resources. During a mass casualty incident, or MCI, which is any incident with 3 or more patients, you must establish an Incident Command System, or ICS. Your first actions are to request additional resources, establish command, and begin triage. The cardinal rule of triage is that treatment does not begin until triage is complete. The 4 triage categories are: red for immediate life-threatening injuries, yellow for delayed serious injuries, green for minimal walking wounded injuries, and black for expectant or non-survivable injuries. The most common triage system for adults is START, which assesses respirations, perfusion, and mental status. When dealing with hazardous materials, or hazmat, always position yourself upwind and uphill. Now let's cover medical legal issues. Expressed consent is given by a competent adult. Implied consent is assumed for unresponsive or incompetent patients. Negligence is the failure to provide the standard of care that results in harm to the patient. Assault is placing a person in fear of harm, while battery is unlawfully touching a person. Your Patient Care Report, or PCR, is a legal document. If you didn't document it, it didn't happen.
Section 6. Pharmacology Basics. As an EMT, your role involves understanding how medications work and administering a specific set of them. First, some core concepts. The generic name of a drug is its simple name, like ibuprofen. The trade name is the brand name, like Advil. An indication is a reason to give a drug. A contraindication is a reason you should not give the drug. The route of administration determines how quickly a medication works. Oral is slow. Sublingual, under the tongue, is rapid. Inhalation is very rapid. Every single time you administer a medication, you must perform the 6 rights: right patient, right medication, right dose, right route, right time, and right documentation. Let's review the core EMT medications. Oxygen, indicated for suspected hypoxia. Oral glucose, used for conscious patients with confirmed or suspected hypoglycemia. Activated charcoal, binds to ingested poisons. Aspirin, an antiplatelet agent used for chest pain of suspected cardiac origin. The patient must chew the tablets. Nitroglycerin, a vasodilator for chest pain. Remember the critical contraindications: systolic BP under 100 and recent use of erectile dysfunction medications. Epinephrine, used for anaphylaxis. The adult dose is 0.3 milligrams and the child dose is 0.15 milligrams, injected into the lateral thigh. Albuterol, a bronchodilator for patients with dyspnea and wheezing from asthma or COPD. Naloxone or Narcan, an opioid antagonist used to reverse an opioid overdose with respiratory depression and pinpoint pupils. Section 7. Obstetrics and Gynecology.
This section covers pregnancy, labor and delivery, and complications. First, a pregnant patient's blood volume increases by up to 50%, meaning they can lose a lot of blood before showing signs of shock. A critical concept is supine hypotensive syndrome. In a late-term pregnant patient, the weight of the uterus can compress the inferior vena cava when they lie on their back, causing a drop in blood pressure. Transport these patients tilted or lying on their left side. Antepartum emergencies are complications before delivery. An ectopic pregnancy is a life-threatening cause of internal bleeding. Abruptio placentae is the premature separation of the placenta, causing severe pain and dark red bleeding. Placenta previa is when the placenta covers the cervical opening, causing painless, bright red bleeding. Preeclampsia is hypertension during pregnancy. If it progresses to seizures, it becomes eclampsia, a true emergency. There are 3 stages of labor. The first is dilation. The second is expulsion, which ends with the delivery of the baby. The third is the delivery of the placenta. You must prepare for delivery on scene if birth is imminent and crowning is visible. Know how to manage delivery complications. A nuchal cord is when the cord is wrapped around the baby's neck. Try to slip it over the head. If it's too tight, you must clamp and cut it immediately. A prolapsed cord, where the cord presents before the baby, is an extreme emergency. You must place the mother in a knee-chest position and insert a gloved hand into the vagina and physically lift the baby's head off the cord. Maintain this position and transport immediately. A limb presentation cannot be delivered in the field. Transport immediately. After birth, your immediate newborn care priorities are drying and warming the infant to prevent heat loss and stimulate breathing. The APGAR score is assessed at 1 and 5 minutes after birth. It stands for appearance, pulse, grimace, activity, and respiration.
Section 8. Patient Assessment. The patient assessment process is the single most important skill for an EMT. It has 5 components. First is the scene size-up. Your priorities are your own safety, BSI, scene safety, determining the MOI or NOI, the number of patients, and if you need additional resources. Second is the primary assessment. This is a rapid, hands-on evaluation to find and treat immediate life threats, form a general impression, assess the level of consciousness using the AVPU scale, alert, verbal, painful, or unresponsive. Determine the chief complaint. If there's major bleeding, use the CABC approach and control it first. Otherwise, assess the ABCs: airway, breathing, and circulation. Finally, make a transport decision. Third is history taking. Use the OPQRST mnemonic to investigate pain, onset, provocation, quality, radiation, severity, and time. Use the sample history for a general medical history, signs, symptoms, allergies, medications, pertinent past medical history, last oral intake, and events leading up to the incident. Fourth is the secondary assessment. This is a more detailed physical exam. For a trauma patient, you'll perform a complete head-to-toe exam looking for DCAP BTLS. For a medical patient, the exam is focused on the chief complaint. You'll also get a full set of baseline vital signs. Finally is reassessment. This is an ongoing process of monitoring your patient. For an unstable patient, reassess every 5 minutes. For a stable patient, every 15 minutes.
Section 9. Pediatric and Geriatric Care. Our final section covers special populations. First, pediatric patients. The most important principle is that children are not small adults. Their airway is smaller, their tongue is proportionately larger, and infants are obligate nose breathers. Bradycardia, a slow heart rate in a child, is a grave sign, most often indicating severe hypoxia. Hypotension is a very late sign of shock in children. To assess a child, use the Pediatric Assessment Triangle, or PAT. This is a rapid, hands-off tool. You assess their appearance, their work of breathing, and their circulation to the skin. Common pediatric emergencies are often respiratory. Croup is a viral infection that causes a sealbark cough. Epiglottitis is a life-threatening bacterial infection that causes high fever and drooling. Do not attempt to examine the throat of a child with suspected epiglottitis. Now for geriatric patients. They present unique challenges due to the physiological changes of aging. The most critical concept in geriatric care is atypical presentation. Do not dismiss vague complaints. A heart attack may present as confusion, not chest pain. A new onset of altered mental status is a sign of a serious underlying condition until proven otherwise. Falls are the leading cause of injury in the elderly. Always suspect a potential medical cause for the fall and have a high index of suspicion for head injuries and hip fractures. Use the GEMS diamond for your assessment: geriatric patient, environmental assessment, medical assessment, and social assessment.
And that is a complete breakdown of the 9 essential sections of the NREMT curriculum. We've covered a massive amount of information, from airway management to caring for special populations. Now that you have the knowledge, the next step is to put it to the test. Head over to our website, NREMTpracticeexam.com, where you can take our free practice tests and download this entire guide as a PDF, along with a detailed explanation of each topic's doses and things we might skipped in this video. Thanks for watching, study smart, and good luck on your exam.